Professor, what chapter are we going to go into right now?
22.
Thank you.
Did he hear everything I just said?
No, he didn't.
Professor, I have a question.
Yeah.
What time are we taking the final next week?
8 o'clock.
Okay, thank you.
Did Dr. Atik already tell you that he's not giving the test on the same day?
Yeah, he said he's giving it on Wednesday.
Cool.
He said you were giving it on Wednesday and we were taking his on Tuesday.
Whatever you say, Alicia.
Professor, can you like record like a review or something?
No.
Oh, okay.
I sent an email for the recording for that 30-minute session we did. Can you see if you can read that? Because I didn't have to upload that thing to YouTube. Can you see if it works?
It works.
The one on April 7th that you sent?
No, for today, April 14th.
Does not work. It says enter a password.
Yes, so does mine.
Okay, so I'll have to download it and alrighty. Okay, let's continue. Do you see the textbook?
Yes.
Okay, chapter 22. This is now management. So this is how we care for our patient with cancer. So we're finished with how cancer develops. We talked about risk factors. We talked about signs and symptoms, and finally, how to prevent it. Now let's begin with cancer management. I won't go with this because table 22.1-1, if we do this, then that means we'll have to go through this chapter, meaning in order to discuss bladder cancer, we'll have to go to chapter 66. Brain cancer, we'll have to go to 45. Breast, we'll have to go to chapter 70, and so on. We're not doing that. Because the reason is cancer management is the same wherever it is. Regardless of the type of cancer, each cancer patient will receive 3 main therapies. So the oldest form is surgery. That was the first one used to manage cancer. If you had a tumor, then they'll take it out. And then we discovered chemotherapy, so now using drugs in order to treat cancer. And then finally, we discovered radiation therapy. We won't cover the newer treatment modalities, namely immunotherapy. The reason is it's not within reach for the ordinary person. Immunotherapy remains very expensive, so it's not mainstream treatment. We're hoping someday it will be. So for our testing purposes, we'll only cover the 3 traditional treatments for cancer, which are again surgery, chemotherapy, and radiation therapy. Okay, let's begin. Regardless of the location of your cancer, it has common impacts, especially if it is already metastasizing, or even if it's not. Every patient with cancer will have these effects on them. So this is on top of the cancer itself. So besides having brain cancer, for instance, the patient will have immunity and clotting problems. We'll discuss this later when we go into management as well as the complications of cancer. It will affect GI function. Have you ever seen a patient with cancer with such a good appetite, looking very healthy, well nourished?
No, they lose
No.
weight.
No. Some patients will have peripheral nerve sensory perception, meaning they'll have neuropathy problems. These are in effect either caused by the cancer itself or the treatment, specifically chemotherapy. There is central motor, meaning CNS, and also sensory function problems, respiratory and cardiac function problems, mainly if the patient has a cancer around the torso or as a complication, or specifically we'll talk about oncologic emergencies toward the end of the chapter. And then finally there is pain. Okay, so that's what comfort and quality of life is referring to. Most people with cancer will have pain. How they affect that, they are discussed in the succeeding paragraphs. I won't read the whole thing for you. I'll just briefly discuss the most important points. So impaired immunity and clotting. Treatment for cancer specifically will have effects on the bone marrow. In fact, chemotherapy has myelosuppression, which is bone marrow suppression, as its #1 problem. And you already know what cells are produced in the bone marrow. They are all, are we recording? Yes, okay. They are all the blood cells. Okay, all your blood cells, namely red blood cells, white blood cells, and your platelets are produced in the bone marrow. So when you have bone marrow suppression or myelosuppression, so you'll suffer from pancytopenia, namely you'll have anemia, thrombocytopenia, and neutropenia. We'll discuss nursing management of those in this chapter. Altered GI function. So appetite is not your best friend when you have cancer. Not only do you lose appetite, but you also have alterations in your taste. So of course, without that, if you don't have any taste sensation, so you won't have any appetite. You physically may not have enough energy in order to eat, okay? Or if you have severe pain, for instance, nobody eats when they're in severe pain. So it's a lot of factors affecting nutrition. In colorectal cancer, for instance, or let's say esophageal or stomach cancer, that will also not only affect ingestion of food, but as well as absorption of food. So it may be necessary to alter the patient's nutrition. So we may have to put in a, for instance, enteral feeding instead of oral, by mouth feeding. It may not be possible. Or in severe cases wherein the GI tract is not available anymore, so patient may have to live with parenteral nutrition or IV nutrition. You've heard of TPN. So these are some of the changes. A patient may need tube feeding or even parenteral feedings. Altered nerve function. We just finished PAD, so this will result from chemotherapy, for instance. So you'll have peripheral neuropathy, the same neuropathy as a PAD patient or a diabetic patient experiences, which will put them at risk for injury. Motor and sensory deficits, these are now referring to specifically spinal cord compression, which is an oncologic emergency. So if there is cancer spread to the bone, that will lead to weakening of the bone, and specifically if it involves the vertebrae, then you'll have compression fractures, for instance, and may lead to spinal cord compression. So that will of course lead to paralysis, or at least paresis. Okay, weakness, or worse will be paralysis. And the worst, of course, is the cancer pain. We have the World Health Organization classifying cancer pain separately. They used to put it under chronic pain, the chronic pain category, but they recognize that it is a special type of pain all its own, although it is a subtype of chronic pain, but they specifically made cancer pain as a separate pain category, which requires special management. Not only the pain, but the resulting complications from pain treatment, namely constipation, which is not a joke either. I mean, I've never been constipated in all my life, so I have no idea how that feels. But I do have 4 sisters who are constantly constipated, and I don't want to talk about what I have to deal with at home when they have it. We have altered respiratory and cardiac functions. These are again tumors that grow in the thoracic cavity, namely lymphomas, for instance, or lung cancer. We have 2 lymphomas. We have Hodgkin's and non-Hodgkin's lymphomas. On top of that, the patient may have oncologic emergencies. This one specifically, we'll talk about it toward the end of the chapter. This is a compression of the superior vena cava because of a growth of the tumor, compressing it. And again, we'll discuss the signs and symptoms and management of this emergency later. So let's go now to cancer management. The oldest form, again, is surgery. There are different types or more like purposes of the surgery. Each one is described here, and I'll have probably 1 or 2 questions on this on the exam, and I'll use the examples that they gave here. For instance, prophylactic surgery, from the word prophylaxis, so this is cancer prevention. So this was mentioned under primary prevention in chapter 21. So this is an example, the removal of polyps as they are discovered. Since we know that polyps can develop into cancers, or they're better removed upon discovery. Diagnostic surgery, the example is a biopsy. Biopsy, by the way, is the only way to confirm cancer diagnosis. There's no other tests. We do have tests like, let's say, tumor markers, for instance, to give us an idea of the most likelihood of cancer. However, those tests are not cancer specific. What I'm trying to say is those tumor markers are not exclusive to cancer, meaning they're also present in other non-cancerous disorders, making them non-specific tests for cancer, meaning they would not give you a diagnosis of cancer. So only a biopsy will confirm the diagnosis, which is, of course, to get a tissue sample and do a cytology study to confirm whether or not it is cancer. Curative, as the name implies, this is to cure the cancer. So this will remove all cancer tissue. Surgery is seldom used alone. Especially now, the tumors that we have nowadays, the cancer we have in today's age. Surgery may be the bulk of it, but usually it's followed by some form of chemo or radiation. Or sometimes they'll begin with chemo and radiation to shrink the tumor before they can do the curative surgery. Other purpose of surgery is to reduce, or this is what they call debulking surgery, meaning obviously this may or may not be curative. The purpose of this is obviously to decrease the size of the tumor. So for instance, this may be part of palliative surgery, but not necessarily. An example would be, let's say you have a large glioblastoma or a tumor in the brain. If it's in such a place wherein it's impossible to remove, then that surgery, which is the purpose of which is just to control the symptoms, for instance. So let's say if the tumor is so big and it's causing such increase in intracranial pressure, which induces nonstop seizures in a patient, for instance. So debulking surgery may be done not to cure the cancer, but to reduce the symptoms, which in essence falls under palliative surgery as well. But when we say palliative surgery, doesn't also mean it's necessarily end of life, meaning you can have palliative surgery earlier on in the cancer treatment. Okay, so but the purpose of palliative surgery is to, it may be used together with cytoreductive surgery. Again, the purpose here is to promote comfort, meaning to reduce or eliminate pain that the patient is experiencing. And finally, reconstructive surgery. Obviously, the cancer is relatively cured. All we're doing is just either restoring function or restoring the appearance, or both. Returning it to pre-cancer status as close as possible. So I'll give you the surgery and then ask you what the purpose is, or vice versa. I'll give you the purpose of the surgery and then you identify an example. Side effects of surgery is pretty simple. It really depends on what did we remove or what did we alter. Although the paragraph gives you specific examples, for instance, where's the example? Right here. So for instance, head and neck surgery. So let's say you had laryngeal cancer. So that would involve removal of the larynx. As a result, what do you think the patient will look like after removing the larynx? Mr. Pekchi? Hello? Okay, so we're having, you guys still with me?
Yes.
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 So for instance,
Still here.
may result in the patient not being able to talk, or they may end up with a tracheostomy, for instance. All right, so that's an example. So let's say a patient has removal of the stomach or removal of the entire GI tract. Okay, so it could be, maybe not the entire GI tract, maybe the small intestines or the large intestine. So that will result in either an ileostomy, colonostomy. So we have different consequences. Okay, again, the consequence of the surgery really depends on what did the patient have removed. Of course, it's common sense. Obviously, we did not remove a vital organ because I mean, you'll be dead. So the organs that we can afford to remove are, of course, all non-vital. So let's say breast, for instance, or one kidney, although you technically can live without both kidneys because you can do dialysis. But obviously, you can't live without a heart or without lungs, although you can have part of a lung or one lung, right? Any question on surgery?
No.
So please read the rest. Obviously, let's say you have cancer of the bone, for instance, which is rare, like osteosarcomas. So which are usually childhood cancers. So if they lose the leg, then of course they are now amputees, okay, which will impair mobility. Although the younger you are, they do recover pretty quick. And we have advanced prosthetics now, wherein we have amazing athletes who are amputees. Radiation therapy. So we have two types. It comes in two forms. You can control the amount of radiation. Generally speaking, radiation therapy involves local treatment, but not all the time though, because when we go into internal radiation, or which is a subpart of brachytherapy or internal radiation, it may go systemic now, because we are now either injecting the radiation seeds, or we are having the patient ingest it. But when we're talking about external radiation, let me demonstrate it. Okay. So let's say this is wants to be the patient.
Oh, I got her too.
Who is this?
I'll do it.
Who are you?
Alicia.
Okay, so let's say this is Alicia. All right. So she receives teletherapy. Tele meaning far, or this is also called external radiation. So the radiation source, so this room that she's in is at a radiation center. So she goes in there, receives her radiation therapy. So the radiation source is inside the treatment center. So she stays there for a few hours, gets radiated. Although we do have precise instruments now, meaning we not only can we control the amount of radiation, but also making them precise, unlike before, wherein the radiation was like a shotgun, wherein there's a lot of collateral damage. It's much more advanced today. We also have position stabilizing devices like fiberglass, making the patient immobile. We can put molds, forcing the patient to assume a certain position so that our treatment is accurate. So she goes to the treatment center, she receives radiation. So when she goes home, when she goes out the door, is she radioactive?
Yes.
Actually, no, because she never brought the radiation with her. So while she was in here, this is the radiation source. She was exposed to it. So when she leaves, is she radioactive?
No.
No, the radiation source remained at the treatment center. So she's fine. She goes home, she's fine. Understand that part of teletherapy or external radiation?
Yes.
It's what they
Yes.
call external beam radiation. Okay. We also have internal radiation. So internal, or also called brachytherapy, has two forms. This can be sealed or unsealed radiation. Brachy means near, which makes sense that the radiation is internal. So unlike the external radiation we saw earlier, this one is inside the patient. So an example would be breast cancer. So let's say this is the breast, and after surgery, so let's say we removed a huge lump here, a huge mass. So after removing the mass, so now the patient has some space here, right, where the mass was. Internal radiation can help finish off any remaining cancer cells that may be left from surgery. So what they'll do is, so let's say they'll have applicators like this. They're small sticks, kind of like the sticks they use for edible arrangements. Oh, you put those nice fruits, and then they stick them on these sticks, and they have a nice arrangement. Okay, so you played with those sticks, right? Those plastic white sticks that are holding the fruits. So it's similar. Instead of fruits, though, they have tiny radiation seeds. These things are sealed, though. So they have some form of covering, and then the radiation is inside. So what they do is wrap these together, bunch it up, and then stick it up in here, inside. So they'll leave the surgical incision open, and then they'll just tape this in place. And of course, we'll have a small dressing there just to keep it in place. And then the patient has radiation inside her. However, it's sealed. So although the radiation is in the patient, it's technically not inside the patient's body fluids though. So this one does not enter the patient's body fluids because the radiation is sealed. Unsealed radiation, which I'll show you under the thyroid hyperthyroidism, as treatment of hyperthyroidism, this one is unsealed, so therefore this one is either oral or IV.
Sorry, Professor, does that increase the risk for metastasis with unsealed?
No, because this is a radiation, meaning I'll show you an example later. But however, the form, since it's oral or IV, you ingested it. So this one is digested, it enters the bloodstream. This one is obviously bypasses the GI tract, goes straight into the IV. But either way, these two will enter systemically, either by the oral or IV route. So since they're now in the bloodstream, can they now enter body fluids?
Yes.
Yes. So you will therefore observe different precautions depending on what the patient received, either sealed or unsealed. So this type now will enter body fluids. So I'll show you the precautions.
Is that why when they say like, I've walked into patients' rooms before and they'll have like a precaution for like chemotherapy or some kind of radiation therapy, when you walk into the room, like they'll have that poster like on their bathroom?
Yes.
Yeah, so I feel like so that's like related then, right?
Yes. Not probably for chemotherapy, because in chemotherapy, it just tells you that the patient is at risk for infection. So it's more like reverse isolation, meaning they're protecting the patient from you rather than the other way around.
Gotcha.
Right? Okay, so it's a protective isolation, but not because the patient is harmful to you, but I'm talking about chemotherapy, right? Because chemotherapy again causes bone marrow suppression.
Right.
So the patient has no way to protect themselves. So they are vulnerable. They are at risk for infection. Not only that, they're at risk for bleeding. They also have severely low red blood cells at the same time.
Okay.
So let's finish radiation. So this is the concept we follow for protecting not only the patient, but ourselves. Because especially if we're talking about internal radiation, now the patient carried the radiation source with them, unlike external radiation, wherein it never left the treatment center. So this is the principle. So radiation will penetrate all other material except lead. So what do you think our shielding will be?
Lead.
So
Okay, so the aprons we will be using is made of lead. So we have several things to consider. Namely here, it's mentioned here, there are 3 factors to determine it. One is the intensity, which is the dose of the radiation. The duration, which is time, how long is the patient exposed to it, and then how far are you from the radiation source. We're talking about not only, again, the patient here, but the caregivers, which includes us nurses. All right, the patient needs that radiation, but we don't. And remember, under chapter 21, what is a consequence of radiation? What could this potentially develop in the future?
Cancer?
Another form of cancer. All right. So of course, we try to reduce our exposure to radiation as much as possible. This is something we need to understand how radiation therapy works. Although radiation kills some cells, it doesn't kill all of them at the same time. Meaning the cells, the cancer cells, actually doesn't distinguish whether it's cancerous or normal cells. So all the patient's body cells absorb the radiation. So it doesn't only kill them on exposure, but days or weeks later, meaning because the cells absorbed it, as stated here, some of them die immediately and more die within the next few days. And then some tumor cells are unable to divide as a result of single treatment. But however, change all the tumor cells here to normal cells, because it also applies to normal cells. So some normal cells are also unable to divide as a result. Again, this treatment does not distinguish between cancer cells and normal cells. So all good and bad cells are exposed to and are damaged by the radiation. So I already described external beam. Again, the patient is not radioactive because the patient never brought the radiation out of the treatment center. Advanced forms here are known as cyberknife. You probably heard it. We have Winthrop, famous for cyberknife. That is actually a form of radio surgery, meaning no scalpel surgery. Okay, so that's what they call gamma knife. A more advanced form is the cyberknife. We also have markings. Okay, so this will help deliver the radiation therapy in a more precise manner. For instance, if your tumor is right where your left throat and below, it's more on the left side of your throat, but above, inside, behind your left nostril, for instance. Okay, so that's a nasty place for a tumor to have. It will be difficult to target that with radiation, correct? So these devices that we use, tattoos, ink outlines, or even these position fixing devices, which are made of body molds, which can be fiberglass or foam. Okay, so this will help position the patient more accurately to deliver a more precise radiation treatment. So that, let's say the patient holds their head toward the left and up, for instance, they may not remember to assume that the next time they come for treatment. So to help them remember, we put body molds. So we just put the mold over the head, and that will force the patient to assume the position they did last week, or they assumed last week. Here is brachytherapy. It didn't say near, it means short. Okay. So with all internal radiation, the radiation source is within the patient. So while that radiation source is in there, they are radioactive. Okay, so they pose a harm to the patient. Let's describe the, here's an example right here, but let's finish the statements here. So one example of brachytherapy, as I mentioned earlier, is for treatment of hyperthyroidism. It can also be used to treat thyroid cancer. RAI 131 or radionuclide iodine 131. This is the therapeutic form of radioactive iodine, because there's a diagnostic form which is named something else. You'll discuss that in your 5th semester under hyperthyroidism. So this is one form of internal unsealed radiation. Now, here's an action alert. So if the patient is receiving unsealed radiation, because the patient either ingested it or the radioisotope was injected to the patient, so either way it entered the patient's bloodstream, so therefore anything wet coming out of the patient is also radioactive for a short while. So these are your guidelines. So while the radioactivity is present, there will be no pregnant women. So that includes nurses. Pregnant nurses can't care for this patient, nor visitors, and children also are not allowed. Okay, and be careful. There should be extra care when handling excreta. Urine, saliva, stool, reproductive fluids. They're all radioactive. Doesn't mention sweat, so probably sweat is okay. But really, I've never really remembered sweat being carrying anything. Probably fungus. Yeah, maybe fungal infections are present in sweat, but not anything else. Now, solid implants are, of course, sealed implants. So if the patient has a solid implant, so again, the patient did not ingest that, although it's radioactive, so therefore you still observe time, distance, and shielding when caring for this patient. However, anything wet coming out of them are not radioactive. Okay, so clearly says here, so for a certain time, while the radioactive implant is in there, however, it's sealed or solid implant, the body fluids are not radioactive. Okay, so this is your care now. So I'd like to emphasize this is a sealed one. So we remember sealed radiation sources are also called solid. So the patient is radioactive because they are carrying it inside their body. However, the body fluids are not radioactive. Okay, so this applies to the sealed radiation. So therefore, these are your precautions. Kevon already mentioned this one. There will be a sign that the patient's room is radioactive, so do not enter without proper shielding. We use lead shields, which is an apron, kind of like the same aprons they use in the dental's office when you get x-rays of your teeth, right? You remember that, right? They put the apron on you, also around your neck. Okay, so these are the same shields you'll be wearing. Only if you're going to have close proximity with the patient, meaning any activity wherein you'll be all over the patient. So let's say you're changing the patient, for instance, doing do duty, or inserting an IV, giving medications, right? So taking vital signs. So when you're within 3 feet of the patient, then you should be wearing lead shields, okay, or aprons. Otherwise, then stay to the as far away from the patient. When you are in that patient's room, though, you should be wearing a dosimeter film badge. So this is not a lead apron. Okay, this is just a meter that tells you how much radiation you have been exposed to. So each person should have one. Obviously, you can't pass this around because you have to measure how much you are receiving. Because if you pass the same badge to another person, then of course you're adding it up. So that doesn't make sense. Here's a reminder, this is not a lead apron. Okay, so this badge is only a meter, indicating how much exposure you've received, okay, while caring for that patient. So you should also always watch that badge to keep track with your radiation exposure. So we said lead apron, and anytime you are caring for the patient, when you are very close to them. This of course applies to the patient. They plan to conceive, not a good idea. You'll have the weirdest looking child if you get pregnant. Again, no visitors. Here, time and distance. Okay, so the time of exposure, because of course these are cancer patients, of course we encourage visitation, but not if you're pregnant or if you're under 16. So for visitors, 30 minutes per day, and they should stay 6 feet away. Okay, so they can enter the room, but the distance we observe now, 6 feet away from the patient. So again, this is sealed. So in sealed, the patient has a shorter time to visit, and they should also stay farther from the patient. Okay. Something that may help you remember is, imagine solid implants right here. I don't know what will help you remember. Sealed, so it's shorter time and farther distance. Okay, I'll leave you to remember. However will help you remember these details here. Okay, in the rare instance that these things fall off, so let's say they had a cervical implant, they got up, it fell out of the cervix, now it's on the floor. Never touch it with your hands. So use long handled forceps, of course, with the apron on, and then put it inside a lead container. There should be one in the room if the patient has a implant. And then this one here, this doesn't mean that the patient's body fluids are radioactive. Okay, so this is sealed radiation. Again, it does not enter body fluids. However, we want to avoid exposure to many people, meaning we'd like to limit the amount of people going in and out of that room. So for instance, if you're the RN and you're going in there to give medications anyway, so you might as well go in there and take the vital signs. So don't say, oh, you're the CNA, that's your job, go in there. I'm not doing that, right? So I'm saying maximize the time in there. So if you have dressings and linens in there, just keep them there, all right? So again, we try to limit other people's exposure to the radiation as much as possible. Side effects of radiation. We have acute and late effects. They're not really that hard to remember. Again, just remember the effects that the cells absorb the radiation. So therefore, some cells die today, some more cells will die in the next few days or the next few weeks. So this is related to the location. Again, generally speaking, if it's external radiation or solid implant radiation, which is sealed radiation, your side effects are more local. Unlike if you ingest the radiation, or if you have been injected the radiation, then it becomes systemic. So I'll give you, the question will be, let's say the patient receives radiation to a certain area, and then I'll ask you, so what side effects or complications are likely to occur? So let's say if I ask Ms. Bowman, the patient receives patient with cervical cancer receives radiation treatment. Which of the following will be your expected side effects? Cervical cancer, radiation. Will you have dental caries?
No.
What will you have?
Wait, I'm not
Where is your cervix?
below.
Below the
Dental
neck?
esophagus, esophagitis, pharyngitis, acute.
Your cervix is up there in your mouth?
No, I said it's below, Professor.
So what side effects would you expect?
Pain. You would have the oral herpes. That's it.
Again, I said cervix, cervical cancer, and then the patient received radiation. So cervix is in the abdomen and the pelvic area, right? So these here will be your side effects.
Oh, I didn't hear the question. Sorry.
Okay, I was just wondering, you have a weird location of your cervix.
No, Professor. Sorry.
Okay, all right. Any question on these terms here? What is xerostomia?
Have to do with, I want to say saliva.
Yeah, this is dry mouth.
Okay, I thought so. No, so
Of
that's
course, the radiation will, of course, you can conclude that they've destroyed or caused damage to your salivary glands, right? That's why you end up with a dry mouth. So this is present in acute, and also it's also a late effect, right? And I'll leave you to study this. On top of the local effects of radiation, these are the others. There's some degree of bone marrow suppression that occurs with radiation therapy. Another is fatigue. Patient will have, where is fatigue? It's somewhere here. Okay, here are the others. Well, altered taste, these are already mentioned here, up here. Well, not really, but it can be implied. So you have taste changes here. Oh, here's fatigue. Okay. Some fatigue in radiation can be explained, some can be unexplained. Okay, but that is one thing that happens with patients receiving radiation. Although the fatigue in chemotherapy is more because of the anemia, okay, that one we can explain, but this fatigue in radiation therapy sometimes can't be explained why they have fatigue when everything else checks out fine. All right, skincare, because this is of course in external radiation or teletherapy, because the radiation source is outside, it can have damage to the skin, because let's say we are radiating, you're receiving radiation for lung cancer. Of course, we can't open up your chest and then radiate the lung only. So it has to go through the skin and other tissue layers before it reaches the lung. So there will be collateral damage there. And chart 22.2 gives you a summary of how to care for the skin that has been damaged by radiation treatment. So these areas are extremely sensitive. They are quite painful. So use your hand rather than a washcloth when cleaning them. You do have these ink markings. Again, the purpose of the ink markings is to deliver precise radiation treatment. So those things that must not be removed. Okay, don't erase them. Can they use powders, ointments, or lotions? You know?
No.
Only
Yes, they can.
prescribed.
But only if they are approved. Usually they approve if these are mild, like Eucerin, for instance, or Cetaphil, Dove. Okay, so those mild types. Soft clothing, for obvious reasons, these areas are very sensitive. They are tender, so nothing tight. Protected from the sun, not only during treatment, but tells you here it should be protected from the sun up to a year after radiation treatment. When you do go outdoors, because we do, just like now, it's healthy to go outdoors, get some, nice fresh air outside, but stay away from the sun though. Okay, do not expose yourself directly from the sun, and also no heat exposure. So this will include heating pads, okay, not necessarily the sun. All right, some details here. This mentioned xerostomia was mentioned, and dental caries was mentioned twice, both in acute and long-term side effects of radiation therapy. So the patient is now at risk for tooth decay the rest of their life. Any question on radiation? Yes, no?
No.
Okay, all right. My 40 minutes isn't up yet, so I'll continue with chemotherapy. Thank you for reading. Not there. No. I'll show you when that statement comes up. Okay, so cytotoxic therapy is referring to chemotherapy, meaning using drugs. Chemo, whether it's PO or IV, is systemic. So therefore, unlike external radiation, there is where there is local side effects, with the exception of unsealed radiation. Chemotherapy is always going to have systemic side effects. Number one of which is, of course, bone marrow suppression. Before we move on, let's explain nadir, the concept of nadir. Thank you for reading, Miss Noblock. What is nadir? Or if Jenna is not available, anybody? Can you read this, please?
The time when
Professor,
bone
I'm
marrow
here.
activity. Oh.
Professor, I'm here.
Oh, okay, sorry.
The time when bone marrow activity and white blood cell counts are at their lowest levels after cytotoxic therapy is the nadir.
Okay, so based on what you read, nadir, is this an animal? Is this a food? What is nadir?
It's like
Time, right?
oh wait, I'm
Okay, so nadir is time. So this time varies depending on the drug used. But generally speaking, we can say nadir occurs typically 10 to 14 days after treatment. So for those who know people who are receiving chemotherapy, how often do they receive chemotherapy? Are they receiving it? No, I'm talking about IV chemotherapy. Are they receiving it every day?
no.
Are they receiving it every week?
Yes.
Yeah, they could receive it like once every 3 days. No, I always get confused between chemo and radiation.
Yeah, not for IV. Okay, so IV chemo, except PO. PO chemo can be taken every day, but IV therapy, because of nadir, it's usually prescribed every 2 weeks. Again, what is nadir again? What does it stand for?
Time.
Okay, this is the time when your white blood cell counts are at their lowest levels. Okay, because what will happen during nadir, and then you give the patient chemotherapy, what will be the effect? If the patient receives chemotherapy during nadir,
Is it that it would be too toxic to them?
so if their white blood cell count is at their lowest during nadir, and then the patient receives chemotherapy during that time, what is the effect?
Risk of infection.
Right, so the patient's bone marrow will pretty much be wiped out if we continue treatment during the nadir. So therefore, in between treatments, because nadir occurs, the patient must not receive treatment. Instead, they will receive supportive therapy, meaning we try to increase their immune system. We try to give them drugs to increase white blood cell production. We prevent infection. We protect them from infection. And not only white blood cells, but this will also go with anemia and thrombocytopenia at the same time. Are you okay with nadir?
Yes.
All right. Okay, this is what I wanted to mention earlier. The chemotherapy here will not be tested, meaning the question on the exam won't be about the chemotherapy drug. I'll show you why shortly. However, cancer on the test question, meaning I won't give you too much information. You won't see the question say,
I'm sorry, can you repeat that? Because you just froze for like a good 30 seconds.
okay, the question won't say Jen Perk is receiving cyclophosphamide for breast cancer. Okay, that's too much information. I'm already telling you, oh, she has breast cancer and is receiving cyclophosphamide. Okay, so that's a chemo drug. So instead, I would simply say, Farah is receiving methotrexate. Which of the following will the nurse include in the plan of care? Understand?
And what's the answer?
We'll find out as we continue our discussion. So the drugs I may use on the exam are the following, the ones I highlighted. So I'll give you a few seconds to do the highlights on your own, on your textbooks. But again, I'd like to emphasize the question isn't about the drug. The question, though, does require that you know that these drugs are used for chemo. That's it.
And all these drugs that we're looking at are used for chemo? Because I saw two different topics. I saw the alkylating drugs and the other side said something else.
Well, there are different categories of chemo.
Anti-metabolic. Okay.
Right, they have different classifications. But these are all used for chemotherapy. They just have different actions. Okay. Like here, for instance, some antibiotics are used for chemotherapy. This one, hydroxyurea, is a chemotherapeutic drug. This is PO. This is oral. This is also used to treat, not really treat, but to reduce the episodes of sickle cell crisis in people with sickle cell disease. Cyclophosphamide. This is one of the drugs used for in chapter 17 when we talked about suppressing the immune system to prevent organ rejection.
Which one was that? The cyclophosphamide?
Cyclophosphamide. Then
Okay.
methotrexate, you'll get to know this drug next semester under rheumatoid arthritis and other autoimmune disorders like lupus also uses methotrexate. All right, you done with the drugs? And we end here on vinblastine, vincristine. These are some of the older chemo drugs. They've been around forever. All right, so again, the questions won't be about the chemo drugs. So we're skipping this whole thing here. Our focus is on care of a patient receiving chemotherapy. So this is the statement I want you to read, which will justify why we are not testing chemo drugs. Thank you for reading, Miss Kanisha Tom. Kanisha is now unmuting and she's going to read any second now.
I'll read it.
Okay, thank you, my hero, Mr. Pekchi.
Got you. Chemotherapy is to be given only by registered nurses who have completed an approved chemotherapy program and have demonstrated competence in administering these agents. However, responsibility for monitoring the patient during chemotherapy administration rests with all nurses providing patient care.
This simply means right after graduation, you are not expected to complete a chemotherapy program, meaning you will not be certified straight out of nursing school. Because for one, you need to have a BSN before you become a chemo certified, and the chemo certification is a few weeks. So the NCLEX won't be asking you about the chemo drug simply because you are not certified. But there's a big however here. However, responsibility for monitoring the patient during chemotherapy, not the chemo drug. Okay, so just the fact that the patient received chemotherapy rests with all nurses. So that applies to you guys. So therefore, your responsibility is if the patient is receiving chemo, you're expected to know what are the complications that arise when a patient receives chemo, whether it be oral or especially if it's IV chemotherapy. Understand? Yes or no?
Yes.
Yeah.
Okay.
Yes.
Therefore, it's about caring for the patient. Okay, it's not about the drug administration itself. Okay, so meaning you're not expected to know how to administer it, what are specific to that drug, none of that. Just a few details here. Even if the patient is receiving PO drug, doesn't mean it's less toxic than IV forms, okay? Any chemo drug, whether IV or in tablets, these are all harmful, so they should never be handled with your bare hands. When handling chemo, again, the chemo certified nurses will have special gloves and the proper PPE. Remember this in chapter 13, table 13 dash, I want to say 3, okay? Table 13-3 talked about infiltration and extravasation. So I showed you this picture for exam 1. So this is the, so I'll have question again on signs and symptoms because again, how it will go is, let's say you have a chemo patient on your floor. Since you're not chemo certified, a chemo certified nurse will come to your floor. Of course, that chemo nurse has other duties They're from another unit. So they're simply coming over to your unit to help you out, to administer, to hang the chemo drug for you. After hanging though, the responsibility for monitoring the patient, as stated here, monitoring the patient during chemotherapy is now your job. So the chemo nurse will leave and you'll only call them if if you see any side effects or any complications that arise. So therefore, since extravasation will happen on your watch or could happen on your watch, so therefore you need to know what are the signs and symptoms and when to call. So for this purpose, you'll have to review table 13-3 in order to review the signs and symptoms as well as the interventions. Okay, so here's where I mentioned earlier that PO chemo drugs are just as toxic as IV. I'm not testing table 22-4. Again, we don't have to know this because you are not chemo certified. So skip that part. We'll go now to side effects. Okay, page 394. We have, what was the most common and the most serious side effect of chemotherapy again, which was mentioned at the top of this chapter? That's why we talked about nadir and all that. What is the most life-threatening complication of chemotherapy?
Infection?
Right, resulting from bone marrow suppression.
Bone marrow.
Right. I'm not saying the patient won't die from anemia or thrombocytopenia. Yes, they can, but your number one most life-threatening complication is infection. But we manage all the problems. So it starts with bone marrow suppression or myelosuppression. So namely, the patient will have anemia, neutropenia, and thrombocytopenia. Taken together, all three are known as pancytopenia, just like a pandemic, okay? Other distressing side effects are the following. Alopecia, it may not seem serious to you, but talk about a woman, a single woman at that, okay, receiving treatment and losing her hair. That's a big deal. Other distressing side effects are mucositis. These are large open sores on your mucous membranes. And I mean your mucous membranes start from your mouth down to your rectum. These are large open sores. And these are larger than quarter dollar coins. These can be as big as dollar coins. And the most uncomfortable is of course the pain and as well as the nausea and vomiting. So we'll manage all of those beginning in this section. So let's start with bone marrow suppression. Here is infection. So this is your most serious complication. If the patient doesn't die from cancer, they will die from the infection resulting from the treatment. And moreover, reduced immunity is the major dose-limiting side effect of cancer chemotherapy. Because once the patient gets sick, can we continue with the chemotherapy?
No.
No more. We have to stop and then we'll have to start over if the patient survives the infection, right? So the infection is the more acute problem once it develops. So your approach here is always prevention, all right? Of course, sources of infection can be fungal, bacterial, or viral. Surprisingly, this is the most common result. It's really the patient's own normal flora that causes the infection, because they're okay if they're on the surface, in your GI tract or in your skin. They don't cause any problems because that's where they're supposed to be. But when these bacteria enter the bloodstream where they're not supposed to be, then you have a big problem. So our focus here, therefore, is prevention of infection. So that will be the bulk of your interventions, as well as monitoring for early signs of infection once they do develop one. And here's a good action alert. Take note that these patients have bone marrow suppression. So since their white blood cell count is low, do they have a normal immune response or inflammatory response?
No.
No. So do you have to wait for a really high temperature elevation before you consider that they have an infection?
No.
No. All right, so here, these are self-explanatory. You have signs of infection here, which can be anywhere. It could be upper respiratory, it could be a UTI, it could be pneumonia. Here is your best practice. We will have a few redundant charts here, meaning the textbook tells you what your best practice is, and then this will be followed by patient and caregiver teaching, meaning we don't only practice prevention of infection in the hospital, but also we teach the patient at home. So some of these will kind of sound redundant. I won't read this for you. Please read them on your own. They're easy to read. Okay, so use dedicated equipment. Try to avoid sharing common equipment. Limit the number of health personnel as well as the number of visitors. Okay, so no healthy visitors only. So we observe more strict protocol here and procedures, wherein, let's say, normally we would change the IV tubing set every 72 to 96 hours. Not so for these patients. We change them daily now. We have more frequent vital signs. We expect the patient's mouth every 8 hours, because again, the mouth is not the cleanest place. So they're prone to not only fungal infections, but remember the mucositis that could develop. And then once you have open sores, then those open sores can be infected. So here, tubing will be daily instead of the usual 72 or 72 hours for continuous, or every 24 for intermittent infusions. Here, dedicated equipment. All right, so avoid anything foreign as much as possible. Avoid Foleys, because that will be increased risk for UTI. And here, no fresh flowers or uncooked foods. We call that a low bacteria diet. Very important is this one here. The patient must receive or perform axillary, perineal, and mouth care every 12 hours. Now, these patients, remember, also have anemia, so they'll have very pronounced fatigue, so they would not want to do this. But can they refuse?
Yes.
Yes.
Do you let them refuse though?
No.
I mean, you could
No.
provide education, but
Right, so here, look at this. Some aspects of patient hygiene cannot be deferred. So of course they can say no, but should you allow them to say no? Is it to their benefit if they say no?
No.
I understand they can refuse treatment, but should you let them though? Is it beneficial for them to say no to
no.
hygiene every 12 hours? No, that will promote infection, so they should understand that part. If they're too tired, then do it for them. Is this understood?
Yes.
Okay.
Yes.
All right. So always think of the patient. Okay, I know they're tired. No, they have anemia. It's tiring. They have fatigue. Okay, they're mentally tired also because of the stress of having cancer, the treatment for cancer. But this is for their own good. All right. Okay. Please read the details here about what to do if the patient does develop signs of infection. Okay, so use these are the same wherever you go. All hospitals follow the same protocol. Here's the temperature elevation I mentioned earlier. Again, do not wait for a high temperature, okay? Even over 100, normally we consider fever at 100.4, right? So if they reach 100, don't wait for 100.4 before you report that to the doctor. Here's the redundant chart, or seemingly redundant. This is now for the home, okay? So this is what you teach them at home, how to avoid infection here. I don't know if people actually do this. I mean, I understand toothpaste, but toothbrush, well, apparently they do, because otherwise the book would mention that. Yeah, here. So try to avoid uncooked foods. On the exam, of course, you have to know what are considered uncooked, okay? Like cheese, for instance, salads, sushi, all right? So those kinds of menu. They can't take care of reptiles because they carry salmonella, and do not change pet litter boxes themselves, okay? Let somebody else do it. And avoid working outside, especially in the garden. Okay, sexual intercourse. Wear a condom, even if it's with your if you're a monogamous relationship, if you have one partner, still wear a condom, okay? Drugs now. We have anemia and thrombocytopenia, as well as neutropenia at the same time. So we have here what we call colony stimulating factors. So these are drugs that will promote, I wonder why my time isn't up. So maybe they upgraded my access? Maybe. So this is for anemia. We'll give them Procrit or Epogen. The generic is Apoetin alpha. Please take note of the side effects. These will be questions on exam. So when you give this, these are what you monitor the patient. Same thing for Oprelvicin. This is for thrombocytopenia. So if Epogen or Apoetin alpha increases the production of red blood cells, this Numega is going to increase production of platelets. These are the side effects. So these are drugs, although they're not in the chart. This is where I grab the questions. There is a drug for neutropenia. Let me see if it's here, filgrastim. Right here. This is under table 22.5, but since the side effects are not mentioned here, I can't test it. So just know these are the drugs used for low white blood cell count. So we will administer those, obviously to increase white blood cell production. What page were we at?
$398.
Okay, here. Next thing is for thrombocytopenia. Again, two charts, which may sound redundant. You have chart 22-5. This is in the hospital. And then, so these are all bleeding precautions. 22-6, this is at home, patient and family education. Another reason why you'll see this is at home is this one here, avoid anal intercourse. Of course, we won't see that in the hospital, right? So that's obviously at home. Okay, next problem is CINV. So this is severe nausea vomiting. The nausea vomiting here is obviously not just from chemotherapy, but also from the cancer itself. So there are three types of nausea here. We have acute nausea. We have anticipatory, meaning before they even receive chemo, they already feel nauseous. Obviously, there's acute. We also have delayed, which can occur after the 24 hours. This can occur up to a week after receiving chemo. and breakthrough, which is occurring intermittently during therapy. So you have different types of nausea here. Regardless of the nausea, we need to treat that nausea. However, we have different drugs. So since we have different types of nausea, you have to be relied upon to choose the type of medication in order to treat and manage the patient's nausea. This is critical because if you're nauseous, you think the patient will eat if they're nauseous? No, so that will affect nutrition. So therefore, administration of CINV drugs or your antiemetics, it's one or more given before, during, and after chemo. The list of drugs are here. Chart 22-7. How you study this is you begin with a purpose. How does the drug work? So serotonin antagonists, obviously the ones ending in citron. So you have ondansetron, ganacitron, dulasetron. This one prevents nausea vomiting. Therefore, is it effective if you give it during nausea?
No.
No, so this is better before starting chemo. So this is effective for anticipatory nausea or as a prophylaxis, okay? Of course, you can give it again and again. Usually this one you can give every 4 hours. But again, this is more effective in preventing nausea vomiting. It doesn't work well if the patient's already nauseous. These are your nursing responsibilities and teachings. Next group are neurokinin and receptor antagonists. So this one is aprepitant. We don't see aprepitant on regular floors. This is only found in oncology units, cancer floors. And the purpose of this drug is to reduce nausea. So this would be good for acute, delayed, or breakthrough nausea. The key to this drug is it's seldom used alone. Here, it clearly says here, when used together with a serotonin antagonist, or that's the ondansetron, and a steroid, this drug will control acute and delayed nausea. Okay. Here are your nursing teaching responsibilities. Steroids, the only one approved for nausea is dexamethasone. The other forms or classes of steroids are not very effective. So again, this drug will reduce nausea vomiting. Prokinetics, although this one here says this is the action, but the term itself, it says prokinetic. So this one really increases GI motility. So therefore, if you have motility, normal motility or even increase, so there will be no abdominal distension, so therefore the patients won't have nausea. Again, this reduces nausea. And then finally, we have benzos, also reduce nausea. Now by the manufacturer, benzos are anti-anxiety medications, right? We use this for anxiety, as I already mentioned. We use this to control seizures. So the drug works by decreasing the patient's awareness, obviously puts the patient to sleep. That's why you have these precautions right here. However, have you ever been nauseous if you're asleep?
No.
No. So therefore, if you're knocked out, then you're not nauseous. So you have several drugs here again. Only one prevents it. So we have serotonin antagonist is used for prevention. All the rest are for reducing nausea. There are other drugs. This is not an exclusive list. Okay, there are, we have chlorperazine, which is compazine, and then we have promethazine, not mentioned here. But this is used for, the most commonly used ones for CINV, chemo-induced nausea vomiting. Okay, so here are additional details here, okay, on how to use them. Mucositis, you have a special chart here, or these are again large sores, open sores in your mouth, in your patient's mouth. Chart 22-8. So we don't use commercial washes because mouthwashes, because they contain alcohol. Instead, we'll give them swish and spit solutions. These are a combination of normal saline or salt or soda water. Sometimes they'll add an antifungal in there, or sometimes benzocaine, you know, a topical anesthetic can also be added to that cocktail, just to promote comfort, you know, numb the patient's mouth so that they can at least eat comfortably and you know, with no pain, so they can eat more. Use artificial saliva, or that could be biotin, because these patients may have xerostomia at the same time because of the open sores. Okay, so let's reconcile something here. So we have a patient with anemia, thrombocytopenia, and neutropenia. If they floss, they could bleed. Okay, so that's a problem. But if they don't floss, they could have an oral infection. So to reconcile that, the recommendation is to floss gently once a day. All right, so that will cover you both. You won't bleed because you're doing it once a day only, and you're doing it gently. Plus, at the same time, you're keeping your mouth clean, so that would eliminate the possible contradiction. Alopecia. Hair loss can be on the head or whole body hair loss. You have protections here on protecting the injury of a hairless scalp, because normally we have hair, the hair protects the scalp, but since it's gone, then the hairless scalp is prone to injury. So here are your interventions. Protect it from the sun. Be careful about the headwear that you're applying, especially the wigs. Okay. The suggestion here is they pick out a wig before they lose their hair. We'll skip the cognitive function changes. Chemo brain is possible, but that's very rare. Although I know somebody who has cancer, a good friend actually in California. He said he had this. He said his IQ dropped, but he regained it after he got treated. Chemotherapy, I won't repeat this because this was already mentioned under PAD as well as in diabetes. So the foot care is the same. Here, chart 22-9, if you look at it, it's almost identical with the foot care mentioned in chapter 36 as well as in chapter 64. We will skip the immunotherapy. Again, this is not a mainstream treatment. This the cost is prohibitive. Not all people receive immunotherapy for treatment, and most insurance companies do cover surgery, chemo, and radiation. So we'll skip all these. The next topic will be under oncologic emergencies, and that will be the end of the chapter. See how much we've skipped. Okay, stop here. We have 6 oncologic emergencies, at least for this textbook. Other textbooks have up to 9, so be thankful. Sepsis and DIC, I won't test right now because sepsis and DIC is studied and covered under chapter 37, I think, under shock. Yeah, shock is chapter 37. So this will be covered under 5th semester. Okay, it's too much to discuss. I can't do it in a few minutes. So we'll skip sepsis and DIC. I'll just give you a little overview. Sepsis is, of course, a severe infection. This is now blood infection, and it triggers DIC. So the patient here not only dies from infection, from septic shock, they could also die from DIC. DIC starts with clotting initially for that's the earlier phase of DIC, but what really kills the patient in DIC is the bleeding that follows. Sepsis, of course, that's obvious because the patient again is immunosuppressed in cancer, so that's why they're prone to infection. That's why we make a big deal about infection prevention. Here on, though, are all testable. SIADH, did we talk about SIADH? We did, right? Under fluid and electrolytes?
Not really.
No?
No.
Oh, okay. SIADH, you have a high amount of antidiuretic hormone. This drug is an emergency hormone. Usually this is secreted in times of emergencies. Let's say you have dehydration. So this is automatically secreted by the posterior pituitary gland in an effort to conserve water. However, this thing, unlike aldosterone, wherein aldosterone affects sodium and water, antidiuretic hormone only affects water. So it will act on the kidneys, telling the kidneys to reabsorb water, but not sodium. However, it will indirectly affect sodium levels, because what happens is, as water is reabsorbed, that will do what, Mercy, to your fluid volume? If the kidneys reabsorb a large amount of water,
It would be excess.
all right, so since now your blood is hypervolemic, what happens to your sodium levels?
It'll be increased, no?
It'll decrease.
Decrease.
Right, because is your blood concentrated or diluted?
Oh, it's diluted. It's diluted.
Now diluted. So there is now delusional hyponatremia that results. Although it's only delusional, it will cause symptoms on the patient. So therefore, these are your signs and symptoms. I'll only test based on this chapter. So signs and symptoms of, because the questions here, because these are emergencies, right? So an emergency, are these all life-threatening?
Yes.
Yes, they are.
Yes, so that's why they call them oncologic emergencies. So the questions on the exam, I'll give you either the signs and symptoms, and then you identify the oncologic emergency, or I give you the signs and symptoms, but ask you about the interventions. All right, so the questions will either be simply identifying the signs and symptoms, or asking you to identify interventions. Okay, so the management is here. So because the problems here are two, we have not only fluid overload, which causes hypertension, but the hyponatremia that results. So these are your signs and symptoms here, and interventions are here. So we start with, obviously the patient's already in fluid overload, so do we give any more fluids?
No.
No.
If
So
they're in
that's why
overload?
here- yeah.
Yeah, no, we don't give them fluid.
All right, so that's why I look at your management. Management includes fluid restriction, increased sodium intake, and drug therapy. The drug therapy is not mentioned in this chapter. I'll test that drug therapy another time. All right, so this drugs here is not on this chapter. And this, I believe, in chapter 62, which is 2 semesters from now. Here's critical rescue, still related to SIADH. Again, the patient is in severe fluid overload, so they're at risk for heart failure, hypertension, etc. Spinal cord compression. So this is from metastatic disease. So the patient has cancer spread to the bone, which will now weaken the bone. However, it will also increase calcium in the blood because the bone is being broken down, so the calcium is leaving the bone and entering the bloodstream. So these are your signs and symptoms. Most common is back pain. The patient may have motor paralysis right here. And these are your signs and symptoms of hypercalcemia. And management here is fluids. Okay, so you have IV bolus, and of course safety, because again the patient's at risk for falls here because of the motor sensory deficits. And high dose radiation, and to stabilize the spine you have neck braces or back braces. Yeah. All right. And for hypercalcemia, these are your symptoms of hypercalcemia. So this is kind of related to the spinal cord compression, where the bone is now resorbed. So the patient's calcium level, serum calcium levels increase. And management of hypercalcemia, number one is hydration. We also add diuretics. So it may sound contradictory, but not really. When we give IV hydration, these are large amounts. Look at that, 500 ml per hour. So this will dilute the blood, thereby reducing your calcium levels by dilution. However, when you give the diuretics, specifically, we don't use thiazide. We use only loop diuretics. The loop diuretics will facilitate elimination of or excretion of the calcium here. Again, thiazide diuretics are avoided because they actually increase calcium by causing reabsorption by the kidneys. To correct the bone weakness, meaning the lack of calcium in the bone now, we administer also biphosphonates. You'll discuss these more next semester. Biphosphonates are drugs used in osteoporosis, unless you already mentioned this in pharmacology. Svc syndrome. So this is what the patient looks like right here. So how did the patient end up looking like this? We have tumors here growing in and around the thoracic cavity. So the tumors, these are obviously lymph nodes that that grew tumors. We have several in the thoracic cavity. So these things will end up compressing the superior vena cava. So of course, if this is compressed, what happens to venous drainage from the head, from the shoulders? What will happen? Can they drain?
Can they do what?
And they drain back into the heart.
No.
Oh, no.
So the superior vena cava is compressed or squeezed. So that's why the patient looks like this. So you have periorbital, facial edema, neck edema, shoulder edema, plus you have all these spider angiomas here. That's actually just aesthetics. The problem here really is the cardiac output that results, because there is less venous return, so cardiac output will suffer. Plus the patient will have also difficulty breathing because of the increased pressure now in the thorax with all these tumors. So the patient's complete picture are here. You have, well, I already mentioned the edema. As it worsens though, the patient will now have dyspnea. Okay, and then you'll have signs of airway obstruction. as it progresses. How is this managed? So the patient will have radiation therapy. So as mentioned here, they typically don't do surgery for this condition. To keep the vena cava open, they can put a stent, okay, just to make sure venous return is normal. Okay, so the patient can maintain cardiac output. Plus also reduce the intrathoracic pressure, so that will in turn also relieve the dyspnea. Last one is tumor lysis syndrome. As stated here, unlike other oncologic emergencies, this actually has some good news. The good news is the treatment is working. The proof of that is the tumor cells are dying. Okay, that's why we call it tumor lysis syndrome. The bad news is the patient may also die, because we know that when cells die, they spill out two things. One is potassium, the other is purines or uric acid. So these are the two problems the patient develops now. Again, this is not all bad news. This is again good news. The bad news is the patient may die from hyperkalemia, or they die from, well, it's not really the hyperuricemia. They die from kidney injury, because the hyperuricemia will damage the kidney, and then the patient will die from acute kidney injury. So how do we know? What makes this dangerous, by the way, is this doesn't happen during the acute episode, meaning after cancer treatment, whether chemo or radiation, it happens later. Because remember, we said in radiation, for example, some cells die now, but more cells die later. So 7 to 10 days after treatment, is the patient still in the hospital or at the treatment center? Yes or no?
Can you repeat that?
Let's say a few days after they receive chemotherapy, are they still in the hospital or in the treatment center?
No.
No, they're already at home. So the danger here is tumor lysis syndrome occurs at home when there is no more nurses, no doctor watching these patients. So it's important that you teach the patient signs and symptoms of tumor lysis syndrome. So that will, of course, be signs and symptoms of hyperkalemia, as well as signs and symptoms of hyperuricemia. Okay. So hyperkalemia, I'll again test only what's on here. Let me see what symptoms they mentioned here. It should be muscle weakness, hypoactive bowel sounds, or whatever. Right here. Hi, Lizzie. So we have here early symptoms, lethargy, nausea, vomiting, all consistent with hyperkalemia. And the signs and symptoms of hyperuricemia, of course, are the same as gout. Okay, so you'll have podagra, which is pain in the great toe. Interventions, of course, there will be two interventions here, one to manage hyperkalemia and then the other to manage hyperuricemia. Yes, baby.
Go to bed with us when you're done.
Yes, later. Okay, thank you.
When are you gonna go?
No, I'm in class, baby.
When are you gonna go back?
30 minutes. Sorry about that. So the management here will be, again, managing hyperkalemia. What were the interventions we learned in chapter 11? What's the fastest way you can drop potassium levels?
Hydration?
Oh, that's not.
Oh no, not the thiazide, the other one.
Oh no, what was that? You remember insulin with dextrose?
Yeah.
Oh,
Okay,
okay.
so
Yeah.
remember chapter 11? So we gave the patient insulin with dextrose. What else? We gave diuretics, right? We also gave um, sodium polystyrene, which is KX-late.
You said to prevent hyperkalemia?
To treat hyperkalemia.
Treat? Okay.
Please recall what the other interventions are under chapter 11. And of course, we promote fluids because that will decrease your uric acid levels. Plus protect the kidneys also to maintain urine output. For hyperuricemia, the same management really for anyone with gout, because the problem is the same. You have high uric acid levels. So the management is to help excrete uric acid. You can accomplish that with allopurinol, and here's the management for hyperkalemia. So you have your sodium polystyrene, which is KX-late, either PO or enema. And if severe levels, then we have the insulin with glucose. And if needed, then the patient will have dialysis, which was mentioned in chapter 11 as well. Any questions on oncologic emergencies?
No.
Okay, it is 10:31.